Well, look who's there. Good morning, Dr. Rosensweet.
Good morning, Carolyn.
Oh, it's so nice to see you,
You-
always. Yeah, thank you.
mm,
Um, I've quite a few questions here, so let's get started.
All right.
Ready for me?
Yes.
Gotcha. Okay, so question number one comes in as um, good morning. Oh, by the way, good morning to everybody who's coming up too, as well, women and men alike. We love having you. And thank you for all the questions too. Number one, I have just had a Dutch test. My doctor says my hormones are very low. She says she doesn't even know how I can function with hormones this low. She's recommending a biohormone replacement therapy, but I am really terrified of taking them. My symptoms are brain fog, neck pain, pressure in my neck and head. Um, I have anxiety so badly now that I can't drive anymore. Rapid heartbeat, insomnia, and I cry all the time. Again, I can't drive anymore. I'm 48, postmenopausal, not having a period for over a year. And I thought my symptoms might have been done to COVID, which I had last January, but now my symptoms are worse, not better. My doctor feels strongly that we need to address my hormones, and any advice that you could give would be so very welcome for me.
There's some great news here. And it is that you're 48 and you're 1 year since your last period. And there's a high likelihood of a remedy that'll just surprise, delight you. And because the symptoms you're having sound right out of the textbook of estrogen deficiency.
Mm,
And these hormones are very, very powerful. And when we don't have them, men don't have testosterone, women don't have the four ovarian hormones, the symptoms can be very raucous. Excuse me. And life stopping. I mean, you lose a couple nights sleep and you have mood ups and downs like what you're describing, and that's enough to really stop the train. And the other good news is I think you're very fortunate in a way because 75% of women who go into menopause have symptoms like yours, and 25% don't. And the 75% that do have these symptoms, you're usually very highly motivated to do something about it. I mean, you got to have a remedy for this one. So
and
you be,
how?
so you become very committed and do what you need to do to get this addressed. Whereas the 25% who go into menopause and don't have the symptoms, they don't have much motivation. They look around at women who are having a lot of symptoms and they're going, what's going on with them? I'm having an easy menopause. The issue there is that these women who have no symptoms still are having the major deep losses that occur from insufficient ovarian hormones. So they're still getting the bone loss. They're getting the arterial risk that they didn't have when they were younger for atherosclerosis. They can get the cognitive decline in later years. Their skin changes, their vagina changes. Uh, they lose their muscles. All these things are occurring, but those are slow in developing. And so when you wake up and you're 75 and you've lost a great deal of lower extremity muscles and you're not as strong and at 85 you need a walker because you didn't address the hormones early on. So I don't want to go on and on about this. It's the women who do not have symptoms that the ones I'm most concerned about. So like I'd like to say to the questionnaire, there's some great news here. Number one, your symptoms are stopping the world for you, which is exactly what they're supposed to do. Why they're so raucous is a part of a healing process, as I see it. Nature wants to wake you up, and it wants to stop your world, and it wants to get you to ask a question. what's going on here.
Yeah.
And it wants the real answer. It's not going to say, well, I need to exercise 10 more minutes a day. No, that's not the real answer. The answer is you need hormones. And here you are, it's 2022. Some of the world's greatest molecularly identical hormones are available to you. There's a level of knowledge and skill that can help dial this in to individualize for your own self. It's a miracle. The part that was not so good, and the other miracle is you're only 1 year out. It's perfect timing for you. You're not going to sustain the deeper losses that if you were 5 years out or 10 years out. No, you're going to do well here, most likely. And the part of your question that was not very comfortable was the degree of fright that you developed. And the fright probably came from two sources. And I've said it many, many times in our Facebook Live, that in 2002, women were on hormones for 1,000 years, as were men. And especially since the 1940s in the United States, 40% of the women in menopause were on Premarin and Prempro, very strong horse urine-derived estrogens and an artificial progestin. And they did well. They did really well, and they had less risk for breast cancer, no less. That's the science. And so, but in 2002, there was a false interpretation of a very large medical study. The data spoke to reduced risk for Premarin, and the data was faulty for the progestin, and they declared that there was increased risk. How the data was faulty is they reported something that was, quote, statistically insignificant for one arm of that study. That means in medicine and in science, you have no grounds to make any statement whatsoever. But the press grabbed it and blasted it out as something entirely different, as if there was increased risk for breast cancer, heart attack, and stroke. It scared everybody. So that's what prevails. And here you are, you're scared because somewhere in your mind, you heard that hormones can cause an increased rate of breast cancer. And your provider, I mean, to me, it looks like the vast majority of healthcare providers are still dealing with that false information. That false information was retracted in 2017 by the same study committee that produced the original report in the same journal. They published it in the Journal of the American Medical Association. But hardly anyone's heard of the retraction. In the retraction, they state, after 18 years of follow-up, there is no increased risk of breast cancer, heart attack, or stroke. The remedy for you reversing your fear, if this isn't enough, what I'm saying is download our book, Happy Healthy Hormones, from Carolyn's Ins and Outs of Menopause, Facebook. Read chapter 3, it's on risk, because you need an antidote to that risk information. The opposite of what you fear. Actually, if women who are treated with hormones, even if they're derived from horses, are at less risk for breast cancer, heart attack, and stroke than women who go untreated. So the opposite of what the public believes and what the majority of healthcare providers believe is actually what's true medically. There's a book called Estrogen Matters. If you really want the details, you could buy that book for your doctor so it could help them antidote the fear that all providers were given. And so the science is the women who are treated, I know I'm repeating myself, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke.
Which is a huge thing to say. I mean, it probably blows a lot of women's minds to even hear that.
Yes.
You know?
So also, yes, exactly. And the world's coming around. More and more studies are coming out. God, they just published a study of 7 million American women who are enrolled in Medicare. They got good information about them. And once again, they state, and the focus is on risk for cancers and how hormones play into that. And once again, they say that there's up to a 22% reduction of risk for women who are treated with hormones than women who receive no treatment at all. So there you go.
Yes, and
Do
thank
your
you.
job. Because your healthcare provider has scared you like this and used a test that is not my favorite, but we're cross-testing it. I don't want to come up with any conclusions until we examine all the data, because we're comparing all the hormone test methods. And of course, your hormones are going to be super low. In the menopause method, we recommend that you don't test a woman who's 1 year out. But see, in every woman who hasn't had a period for a year, every, not some, every, I'm saying 100% of women who haven't had a period for a year, we're going to see super low ovarian hormone levels. And so, with all due respect to your healthcare provider, who may be so excellent in so many ways and may care a lot, they haven't specialized in treating women in menopause, and I see that. Now, they know something. They're going after a more a type of testing method that we're not certain about. But and yet they wouldn't have scared you like that. That's the thing. So, with all due respect for the excellence that they may have in so many ways and how caring they may be, that speaks to they're not specializing. Because if they were specializing, they wouldn't scare you like that. They'd say, hey, rocket science, you're 1 year out, your hormone levels are low, we're not going to bother testing you, we already know they're low, and here we got a good program for you. She's right about, I'm sorry, I don't know the gender of your healthcare provider. They're right about bioidentical hormone. That's the state of the art to me, without a doubt. And so the recommendation for you to go on hormones and dial them in is an excellent one. Please read our book.
Oh, I was just going to say, please read the book.
You'll see one way to do that. It'll be a good roadmap. And I'll be delighted to connect with your healthcare provider if they would like that. And there's a way to do that if you contact Sherry, or you can contact Carolyn, right, Carolyn?
Absolutely, anytime.
You'll give them my email address, and we can start corresponding. That would be for me to actually consult with your healthcare provider. I'm not able to take new patients other than that.
Bummer. Big bummer. But thank you very much for that really nice answer. And you know, you always say it's those women, the women that you know, look at you and say, "Oh my God, I'm so glad that I'm through with that." Well, they're not exactly through with it, in my mind, at least, when I'm seeing them walking with a cane, and then I see them in a wheelchair, not taking hormones. To me, it's kind of sad. But anyway, again, thank you for that answer. Let me move on to number 2. When getting our hormones up right before a period, and the questioner is saying I am in perimenopause, how do we know we have reached our right levels? For me, spotting and bleeding are not indicators of this for me. Is that a question you understand?
Yes. There's a couple ways to assess whether you're at the right levels. One thing, I pause there because there's not enough information, but I can answer what there is there. And we have a very rigorous approach to helping you determine what the right levels are. These hormones are so powerful that the absence of them for 75% of the women result in 1, 2, 3, 10 life intense stopping symptoms. You wake up in the middle of the night, you can't sleep, you have hot flashes during the day, your mood's all over the place, you get vaginal dryness, long list of symptoms. And again, if you download the book, where very specifically we list those symptoms. So after our initial consultation, which is quite in depth, we really want to learn a lot about you. We'll begin hormones. We'll begin 4 different hormones in almost every case. You're missing the estrogen. So we're going to start you with bias. All this is very detailed described in the book. We're going to give you an estrogen. We're going to give you a progesterone. We're going to give you a combination of testosterone and DHA in most cases. The symptoms of estrogen deficiency can be so raucous that as we start low and you gradually increase the dose of the estrogen that we're prescribing, the most likely thing that's going to happen is you're going to feel better. And you're going to go, oh my goodness gracious, these estrogen insufficiency symptoms are getting alleviated by, I'm not having 20 hot flashes a day and night, I'm down to 3. We gradually increase until we alleviate the symptoms. So that's one way we know that these things are working. And the same is true for progesterone. There's progesterone insufficiency symptoms, there's testosterone insufficiency symptoms. We start low with prescribing the dosages for each one of those. We gradually increase, and along the way, we alleviate symptoms of insufficiency. Now, you can go too high. You can keep on increasing and get into too much, in which case you're usually going to get symptoms of overdose. So these things are so powerful. I mean, you give most women too much estrogen, they're going to get overstimulation of their breast glandular tissue, and they're going to get breast tenderness, breast fullness, and there's a list. And this list occurs in several places in our book, Happy, Healthy Hormones. So if a woman goes too high, we have her back down. Then there could come a day, which is almost certain, it may take a month, it may take 2, 3, 4, but somewhere along the line, the woman who is going through this process of dose determination by symptom alleviation, she's going to say, oh my God, I feel better. I think I got it. I think I figured out my dosages. And at that point, we test 100% of the women, and we use the 24-hour urine hormone test, which is, at this point, this is the only one I'm willing to really stand behind and go, it's most excellent. And we'll also get a sense of whether the test confirms that they're on the optimal dosages. We know that it's widespreadly believed.
Widespreadly believed, yes. It's more better.
Believed that all you have to do is alleviate symptoms and you'll be fine. No, that is not true. And how do I know that? Because one year I was teaching at a certain large organization, and I decided before doing that teaching that I was going to examine the 24-hour urine hormone test of 54 of the women that I treated most recently up until that. And I put all their results out on a spreadsheet, and all of these women had said, I feel better now. I think I've got my dose. Well, 50% of those women, even though their symptoms were alleviated, they had dosages of estrogen insufficient to protect their bones and vagina. That's a big deal, because it probably even takes more to protect your brain and your arteries. But we know the numbers. The medical science and the medical literature reveals what the proper low end is, and you don't want to drop below that. So 50% of the women who felt good did not have sufficient estrogen. Their symptoms were alleviated, but they did not have enough to protect their vagina and their bones, and thus probably nothing else. And then 25% of the women, they felt good. They had dosages of estrogen, for example, that were more robust than what we like to see, and it put them at risk for breast glandular cell proliferation. We don't want that. So there are exceptions, but 95% of the time we don't want that. So there's a nice, wonderful range, not too much and not too little, and we ultimately determine that by the 24-hour urine hormone test. And because a woman who says I feel good is usually so close, we'll just tweak the dosages if they're not in the optimal range, and we very rarely have to test them a second time because it's just a dosage tweak. So that's how we determine whether or not you're in the zone. Now, there's other things that play into this that are very important. And one of them is, how's your bones doing? If someone's got bone loss, there's other things we want to address as well. And how's your mammogram doing? Because all of these different assessments matter. And then we check in with you annually, because sometimes a little bit of tweakage is needed in the dosages, and we test you annually, hormone tests. And we do mammograms at a proper recurrent rate. That may not be every year, but we definitely do them. They're very important. So there's a lot of different ways that we evaluate you. They all matter. We believe in standard of care.
Yes.
In neurology, in internal medicine, in orthopedic surgery. There is something called standard of care. They have a long list of criteria of what constitutes good practice and what's a little bit on an outlier practice. And we feel like we've developed that for hormone replenishing. This is not standardized as of yet. And that's one of the things that our menopause method is working on, is to
like 24/7
specialty and really codify our standard of care. What we do believe we have arrived at that. So there's a lot of ways to assess you. And bleeding, well, it depends. If you're in the perimenopause, you can easily get some bleeding when you're starting to deal with hormones. That's a subject for another question. But if you've been 2 years without a period, for example, or a year without a period, and you went on hormones and then you start bleeding, your dosage is not okay. And in a very rare, but something worth respecting instance, there's an endometrial problem. There's a problem in your uterus, could even be endometrial cancer. Catch it early, and it's 100% treatable cure. But that's pretty rare. But bleeding is most commonly, you're still in the perimenopause and you didn't know it. And in order to be out of the perimenopause, you have to have no menstruation for 1 year officially. And if you've gone beyond that year and you're still bleeding, there's too much hormone dosage, or something needs to be looked in with a transvaginal ultrasound, or even an endometrial hysteroscope. They can look right into your uterus to see if there's anything abnormal in there. This is the province of gynecologists. They have the tools and techniques to evaluate abnormal bleeding. It's very important you do so.
There you go. Thank you. Thank you. Thank you. Thank you. Moving on. Questioner says, I had a questionable mammogram and ultrasound, and now I have been taken off of all of my hormones. Is this the correct thing to do, or is it better to stay on my hormones? I feel I should stay on them, but my doctors just do not feel the same way at all, and they want me off of all of them completely. I wanted to run this by you to hear your thoughts. For me, this is very disconcerting, and I very much appreciate it.
Well, there's a question.
Oh, yeah.
And Carolyn, I'd love to answer that question. That's an extremely important question. But I think maybe even out of respect to someone who's asked us a question in the chat, would you ask that one? And then I'll get to that big one. And I'm even going to have you repeat the big one that you just asked. But the one about stopping hormones.
Okay, on the chat it says, do you recommend stopping hormones for a few days? Is there any reason to do this?
Well, I'm not going to give you a direct, immediate yes or no. It depends, is the message that I'm going to give you. Because when you're in menopause, your body needs a certain amount of hormones. We really know how to dial in that right amount of hormones. But let's say, for example, you were taking 10 extra molecules of the amount that you really needed. So being a little facetious there. Well, gradually over time, because these hormones are fat soluble, you're going to build up a strategic reserve, and your body's going to have too much hormone in it, because it's going to dissolve into the fat tissue, and it just keep building up the amount of hormone in your fat tissue. So we do a ritual to address that. I'm going to give you the gross ritual, then I'm going to give you some caveats. The gross ritual is, in the beginning, let's say you arrive at your healthcare provider and you say, I got my dose. I feel great and I got the right dose. What the healthcare provider doesn't know, unless they do the testing, 24-hour urine hormone testing, what they don't know is, are you on too much or not? But they can prevent that buildup by saying, okay, here's what we're going to do. On the first day of the calendar month, we're going to have you stop all your hormones. And you're going to continue to stop them until you develop the first symptom of hormone insufficiency. So let's say you go 1 day of stoppage and you feel fine, and 2 days of stoppage and you feel fine. And on the third day, you get a hot flash. Well, what went on there is you had enough in your strategic reserve, the fat tissue of your body, to continue to have a certain amount of hormone levels, even though you stopped your hormones. But what we know by that third day when you develop that hot flash is you cleaned out, you ran too low. And so how we prevent accumulation over time is we have you stop once a month. For how long? Well, how long did it take you to get symptoms? In the case that I just gave you an example of, it took you 3 days. Well, we would have you stop for 2 days every month. We don't need you to get the hot flash. That's a little stressful. It's a little tough to recover from that. Not too hard, but 2 days is going to be enough, we say, to prevent that buildup over time.
To prevent that buildup over time. Operative word, yeah.
So I now want to give you a caveat. When I look at a 24-hour urine hormone test, and if a woman said to me, I feel really good, and I can see that she's on the low end of the optimal range, here's the optimal range, she's at the low end, I don't necessarily want her to stop because it's very unlikely that she's going to accumulate. But if she's in the mid-range or the upper end, I'm going to put her through that experiment of, let's stop your hormones and see what happens. Now, let's say that she stopped her hormones and on day 1 she felt great, and day 2 she felt great, and day 3 she felt great, and day 4 she felt great, and day 5 she felt great. Man, that woman's got an internal buildup of strategic reserve. She's the very one that we want to question, is she on too much? Well, the 24-hour urine hormone test is going to tell us a lot there. And yeah, she'd be someone we'd want to stop once a month. So if that happened to be the right dose for her. So we make a choice there. I recommend stopping once a month for how many days? A few days? No, we're very specific about that. How many days did it take you to develop symptoms? 4 days to develop symptoms? We're going to have you stop for 3 days. 6 days to develop symptoms, and your test results are still pretty good, we're going to recommend that you stop for 5 days. It depends on how long it takes for that first symptom to develop. And then for a woman who's running, I call it estrogen lean, she's on low doses of estrogen and are really putting her into the optimal zone on testing and alleviating her symptoms. We don't necessarily have these women stop because it's going to be disruptive to them. They stop, they're going to get a symptom the next day. Who needs the symptom? It's stressful. So you can see there's a little bit of complexity to it, but it's also pretty straightforward. And we describe this in the book as well.
Yeah, that book is good. It's downloadable free, and you can always write me to send you the link if you can't find it, because sometimes it moves up and down or whatever. I'm always happy to help.
Now, should we go back? Let's go back to that question, and please read it again, because
I will indeed. This woman had a questionable mammogram and ultrasound. She's been taking, she was taken off of all of her hormones. She's asking if this is the correct thing to do, or is it better to stay on my hormones? I feel I should stay on them, but my doctors do not feel the same way at all and want me off completely. I wanted to run this by you to hear your thoughts because it's really disconcerting to me. And thank you.
I want to give you a different opinion.
Oh, okay.
That this is the science and the art of medicine. And your doctors give me a hint that they are not specializing in treating women in menopause with compounded bioidentical hormones, because a blanket statement like that would not be made. And bless all of our hearts and bless doctors' hearts. In 2002, that same study I keep mentioning, everyone got frightened. And doctors got frightened to treat women in menopause for a variety of reasons. And the ultimate result, global almost, is a shying away from specializing in treating women in menopause with hormones because they were afraid to put their patients at risk. So, and if you don't specialize in something, you don't get great at it. That's part one. You might be able to do a decent job with common situations, but common situations, geez, is there such a thing? Yeah, there is, but every man and every woman is an individual. And the variation, individual to individual, is rather remarkable.
Yeah.
And so, what I learned early on, and which every physician knows when they've specialized in something, that you've got to treat the individual on the individual case. You talk to an orthopedic surgeon, you talk to a urologist, they have so many tools to try and sort out what's going on with this individual. Never mind the global information I have about the subject. The urologist is going to use a cystoscope and ultrasound and medical history and testing before they go in and do something. They got to figure out what this individual's got going on. And I'm telling you, they really have the tools to do that. And so many specialties do. Well, treating women in menopause, the tools also exist, but you'll hardly ever see someone who specialized in it, because in 2002, the medical profession got as concerned as women all over the world did, that they were going to put their patients at risk. So you see very few specialists. Now, one of the things we have is in the beginning of working with a patient, and anyone who's in the menopause method, you fill out a questionnaire, and this questionnaire, when it's on paper, is 12 pages long. It takes about 45 minutes to an hour to fill out, but oh my, we've been very careful. I personally designed this. I want a lot of information, and that's what's missing in being able to answer this question properly, because this woman could have had breast glandular cell proliferation leading to a questionable mammogram. Questionable mammogram? What in the heck is that? That radiologist who read that mammogram has been specific, and they don't report questionable mammogram. They report specifics. There's fibrocystic situation there. There's a lump. Listen, you didn't have anything significant, or you would have been called back, patient. They would have, if they saw something that can really concern them, they would have said, come on back, let's do an MRI or something to further assess your breasts. No, it's most likely that you had increased breast density. I'm having to make a guess. And that's common. And, that's worth respecting. And that is worth a doctor pausing. But saying no hormones, that's more than we really recommend ourselves.
If I'm sorry, if I'm correct, I believe she's been on hormones since 2008 as well.
Yeah. And yes, thank you. And there's so much more that we want to know. Like, I'm having to guess at what that mammogram read, because they didn't say you have a lump that we're going to follow, or this patient would have, I would guess, would say it. My guess is she had increased breast density and fibrocystic breast, possibly.
Yeah,
And
a questionable, yeah.
Yeah, she could have had that since she was 22 or 32, and it may not have changed. And there's ways to evaluate that change. So we have a very significant evaluation process. We need to know a heck of a lot more about this woman. And there is a chapter in our book called Breast Health. And in it, we outline some of the ways we assess women. And everything in medicine is a risk-benefit analysis. What I mean by that is you go to intervene with a human being and there's risks involved. And oh my God, and this is true about life in general, you can take a risk by doing something and you can take a risk by not doing something. So just recommending, why don't you just go omit hormones? You can pretty much guarantee you're going to put your bones, your vagina, your cognition, your coronary arteries at risk. Everything requires a precise analysis. We treat women with, quote, questionable. Now, you never see the word questionable on a mammogram report. I'm not trying to discount that. That's a general statement that someone could say. I'd understand why a healthcare provider say, well, there's something on your mammogram that was a little questionable to me. We want to know the specifics, and we want to know, is the treatment itself, like overdose of hormones, for example, will increase breast density? Well, we know how to assess overdose, and we know how to back down from dosage. So I would never make a recommendation, a global recommendation, like you come off of hormones. Personally, I would go with great precision to assess your individual situation. And in most instances, all we do is a continual follow-up. Like our method calls for a rigor around follow-up. Let me give you an example. And I've given this example many times. Most women, the amount of hormones they need, they fall within a range. Like, women vary. So some women only need this much estrogen and progesterone and testosterone and DHEA when they're young to regularly menstruate, be fertile, be healthy. Other women need 3 times as much of that. And they're normal. They have 3 times as much as this woman has of hormones, and they're all normal. It's a normal range. And in general, we treat most women right below that normal range, because at the bottom of that normal range, once a month during a menstrual cycle, a woman gets breast glandular cell proliferation. That means she's preparing for breastfeeding whether she gets pregnant or not. If she does not get pregnant during that cycle, the proliferation of breast glandular cells, cellular mitosis, new cells being added, that stops, and all the new cells disappear once a month. So we like to treat below the amount that will give breast glandular cell proliferation, because we don't need proliferation in a 50-year-old woman.
Right.
We don't need mitosis. And by the way, you can get just tremendous benefit from just coming in below. Tremendous benefit for bones, for heart, for all kinds of things, for muscles. But there are exceptions. There are some women that they're losing their cognition, they're losing brain function. And it's a well-known connection in women especially, that insufficient estrogen can lose, because there's so many estrogen receptor sites in the female brain, that a lot of women can have severe cognitive deficiency / heading towards dementia / dementia from insufficient estrogen. There's other causes of dementia, but that in women, that's the most common one, insufficient estrogen. So we will keep on increasing that dose in women who are getting severe cognitive decline, and see if we can get the brain back. And in several instances, we can get the brain back. And in several instances, we really need robust dosage to get that brain back. And the medical literature confirms that. The amount that of estrogen it takes to protect the vagina and bones is quite low relatively. And in most women, that's going to give you everything else you want. But in some women, you need much higher levels of estrogen. In some women, you need such higher levels that you get the period back. That's quite high. To get the period back, you need 3 to 8 times the level of estrogen that a young woman has. That's a whole other story. Well, what does that do? That can produce breast glandular cell proliferation. So what? In the sense that we have the tools to monitor these women. Breast radiology can be very sophisticated. There's all kinds of techniques that we can use if we need to see if there's something in there that doesn't belong there. There's breast health techniques. In other words, it's always a risk benefit. We don't say to a woman who's got her brain back by restoration of robust estrogen doses, well, we got to stop, even though you got your brain back. We don't do that. We just are scrupulous with monitoring breast health. And the dosage that even bring the period back, they may have no effect on the breasts. A woman who has fibrocystic breast disease, increased breast density, she may not get increased breast density. She might. So this is the art and science of medicine. You come up with an idea, you see how it plays out. If it plays out favorably and her mammogram never changes and she does scrupulous breast exams herself, she becomes an expert at her own breast lumps. An expert, there's a way to do that. You can become an expert in assessing your own breast lumps. Breasts are normally lumpy. The glands are lumpy. You can get to know them so that you'll be the first one to feel a change. You couple that with mammogram and thermogram. Thermogram not for breast cancer screening, but for inflammation screening. Like if we see breast dense, we send a woman for a thermogram, not to see if there's cancer or not. The thermography is not capable of that. There's false negatives possible. But it does reveal whether there's heat and increased heat in a breast. That's a sign of inflammation. That's an unhealthy breast. Well, we know how to treat that. You deal with what you have to deal with. So what I'm saying is, this is a woman who should be seeing someone who's devoted their career to specializing in treating women in menopause with compounded bioidentical hormones. That's the task, finding one of those folks. Well, you can contact Carolyn. We'll put you in touch with Sherry. We may have trained one of your providers in your state. It's easier than ever because of telemedicine. That means if there's one healthcare provider, a nurse practitioner, a physician, even a physician's assistant who've been heavily trained in specializing this in your state, you can be treated by telemedicine. It's fantastic. You have to see them once a year because of testosterone. But hey, we've had women fly in from all over the United States and Europe for that one visit to see them in person. So everything is possible. It all depends on the individual patient and the expertise of the provider.
Yeah.
That's your job. That's this patient's job, to utilize their healthcare provider for all the greatness that they currently have with that healthcare provider. But I'm going to make a wild guess that this is not a specialty. They haven't put in the 100 patients, hundreds of hours, the training, the mentoring. We have a very extensive training and mentoring program. We don't certify folks until they've really gone through a rigorous process with us. We have weekly grand rounds with our healthcare providers. So anyone, that's what I want to say. Every case is individual. There's always a way to find the right path. And, there may come a time where hormones are not okay for you, but I would be surprised if that were true. I would say that that hormone is replenishing is important for your whole life. And all you do is you find someone who knows how to monitor you. And yes, there is someone in Austin. Contact Carolyn. We'll put you in touch with Sherry. There's someone who does do our method in Austin.
Yes, please write me. You can write to me via PM. You can write to me at the ins and outs of menopause with David Rosensweet, MD. Easy. And I will get you that information. Absolutely. And I have these questions anyway, so I can get with you later. And I will. Thank you for that answer, Dr. Rosensweet. This is an interesting one. Question number 4, and I want to get to it because we don't have that much time. In your experience, Dr. Rosensweet, I am wondering your thoughts on giving anti-estrogen medicine to women who have had breast cancer and the whys as to why some do and some do not get these estrogen blockers, so to speak, even if the cancer was properly treated. It's really very, very confusing to me, and I thank you so much for expounding on this.
There's a lot of different aspects to this question and its answer. And at the heart and soul of this question is what causes breast cancer and what causes recurrence of breast cancer. And this, I'd like to just go back to the basics and say hormones do not cause cancer. Zero. Do they influence cancer? That's not even known for certainty. But let me go. Cancer does have causes. Cancer can be a life-threatening illness, no matter what cancer it is. And a lot of these cancers are curable these days. That's the great news. And then there's dramatic recoveries that people can't even say how they recovered, but they did. And there's a book out there called Remarkable Recovery for anyone who is concerned that you can't beat a diagnosis. You can. So many people beat diagnoses. Oh my God, I have a family member who's beaten a life-threatening cancer. And my family member is now, I think, 8 years out, 10 years out, free, and had been given a very short, settle your affairs. And it was so you can beat anything. And that's a little bit of a sidetrack there. People do. You name the illness, someone's beat it, someone's healed it. Now, back to the main question, what in the heck causes cancer? Well, I like to do this in my practice when this subject comes up. I like to say that a severe illness, any illness on the planet, has got a multitude of causes to it. You don't get diabetes out of the blue. In almost every instance, there's causes. And you don't get cancer out of the blue. There's causes. So I'll do this with a patient. I'll point to my back wall and I say, let's pretend that I'm going to project a video onto that wall. And it's going to be a video of your life that a videographer filmed you beginning when you were in your mom's womb 24/7 until yesterday. And then this videographer had a magic button. And when they pressed that button, it edited out all the good stuff, all the good food you ate, all the exercise you did, all the happiness you had, all the good supportive things for your health that you did. It edited them out. What left behind is a lot of issues around nutrition, what you ate, toxicity, what was in the food and water and environment that you got exposed to, exercise too much or too little, and how you responded to the stress in your life. Did you respond in a functional, effective way, or did you trigger the biology of fight or flight? And then there's going to be a fifth category, because I just named the 4 reasons why people get ill. I defy anyone to tell me if there's another reason. There is some illnesses you cannot explain by ordinary means. So mysteries. But what we would see on that wall back there is thousands of events where they ate the wrong food, they smoked a cigarette, they did all kinds of things that was detrimental to their health. And we'd see a video of all those causes. And that's what causes illnesses. And those causes can be intense, especially when there's a jillion of them. So that's what causes all illnesses and cancer. But here's some facts about hormones in cancer. For example, I'm a man and I'm at risk for hundreds of cancer diagnoses. And I'm at a special increased risk for prostate cancer, and there's reasons for that. And women are at risk for hundreds of cancers, thousands of diagnoses, hundreds of cancers. And there is an increased risk for breast cancer, and there's reasons why that's so. And again, an examination of toxicity, nutrition, etc., would reveal the causes. Hormones are not that cause. They're not in there. And women who've had breast cancer and have had that breast cancer properly treated, they're at an increased risk for recurrence than a woman who's never had breast cancer isn't getting. Now, knowing all that, here's the science. Women who are treated with hormones are at less risk for developing breast cancer and, by the way, heart attack and stroke and other illnesses. Women who are treated with hormones are at less risk for developing than women who are not treated. And here's another medical fact. And if you've had breast cancer, I highly recommend that you purchase and read the book Estrogen Matters by Avram Blooming and Carol Tavris. Dr. Blooming is an oncologist specializing in breast cancer. He has a study that he's been running for years on treating women who've had breast cancer with hormones. So women who are treated with hormones, this is the science. Dr. Blooming specifies it in over 450 references, medical references.
Pretty incredible.
Women who are treated with hormones are at less risk for the developing of cancer than women who are not treated with hormones. And women who have had breast cancer and have had that breast cancer properly treated are at less risk for recurrence than women who are not treated with hormones.
So may I ask, if it's appropriate, you can say no, why give these blockers? I mean, is it
okay?
Placebo or?
There is a belief, it's just a belief, that if a cancer was found and the cancer has an estrogen receptor site, that means it's responsive to estrogen, that would be a mistake to give a woman who had had breast cancer and had that breast cancer properly treated estrogen. So they think they should, and it's called ER positive or estrogen receptor site positive. They believe, it's a belief that you should not give women who've had breast cancer estrogen because it would cause the breast cancer recurrence. But it's just a belief. Tamoxifen can have some effectiveness, but how it's doing that is unknown. Treating women with hormones can have some effectiveness. So I refer you to Dr. Blooming's book. Like, one thing he did as a study, he had relatives that had breast cancer and they're on hormonal treatment. They're on Premarin and Prempro, no less. And he started studying women who had breast cancer properly treated, that he put on hormones. He's an oncologist, that's a cancer specialist. He treated women who can get so miserable if they've had breast cancer and they lose ovarian function, they lose their hormones. They seem to have an extra miserable factor as possible, not guaranteed, but from the hormonal loss. So he's treated his relatives and many women. He has an ongoing study with hormones. And he started treating women with hormones quite a bit before the estrogen receptor site was even known about and even discovered. That happened in the late 90s. And his point was this: once he discovered the estrogen receptor site, he could not distinguish whether or not it mattered whether they had an estrogen receptor site or not.
Interesting.
It's imperative to read the details in his book. Now, are we concerned in treating a woman who's had a prior history of breast cancer? You betcha. We take special vigilance with treating these women, but in our method, we've been, and many other providers, we've been treating women who've had, because of the science. We know that you're at less risk for recurrence if you take hormones than if you don't. And what's the difference in numbers between what does tamoxifen prevent It's not 100% effective. Tamoxifen is one of those blockers that you were talking about.
Right.
Or treatment of hormones. These numbers are not very different. Like women who have been on tamoxifen for a long period of time, they tend to have less incidence of recurrence. So do women who are on hormones. How big are the numbers difference? Not big, probably not statistically significant. Why? Because cancer is not created by hormones, and that whole area is gray about the estrogen receptor site. There are causes to cancer, and why do women get recurrence? You want to look to those causes. And then there's the mysteries. There's things that we can't explain, and have mercy on us human beings. We're subject to a lot of stuff.
Yes, we are.
This is a lifetime of challenge, that's for sure. And Carolyn,
I know.
I'm willing to pick up this answer next time, but I have another commitment, so I'm going to have to say.
Yeah. So you have to leave us early. Another bummer. But we will not be doing next week. There will not be an interview next week. We will pick up the following week, but it's all going to be on the group, and I'll make sure everybody knows. And I want to wish everybody a really great day, great week, great weekend. Thank you, Dr. Rosensweet, always for your kind time, your wonderful answers. And we will see you a week from Tuesday.
Thank you, Carolyn, for putting all this together.
It is my pleasure.
2 weeks. All righty. Bye-bye.
Bye.